Welcome, and thank you all for joining us today for the webinar AHRMM Data Solutions, Driving Results with Data, the Hospital PMI and AHRMM Keys. Hi everyone, this is Mike Schiller, Senior Director of Supply Chain at AHRMM, and I will be moderating today's session. Some housekeeping items for today's call. All lines have been placed in a listen-only mode, but you can ask questions by typing them in the Q&A box, which can be opened by hovering your mouse at the bottom of the WebEx browser, clicking the ellipses icon, the one with the 3 dots, and clicking Q&A. The Q&A will be held toward the end of today's session. After today's webinar, please complete the evaluation so we can improve our education for you and other healthcare supply chain management professionals. Registrants will receive their continuing education certificate about 2 weeks after completing the survey. COVID-19 has highlighted the importance of using data and the right types of data to assist and guide our strategic planning. Today, we will talk about 2 new data forms with Tom Derry and Steve Kiwi. Tom Derry is the Chief Executive Officer at the Institute for Supply Management. He will begin the discussion about the Hospital PMI, ISM's Hospital Report on Business specific to hospital supply chains, and how hospitals can use this data for actionable supply chain planning insights. Then we'll move to Steve Kiwi, who is the Chief Commercial Officer of Inalair, co-chair of the AHRMM Keys Task Force and AHRMM's chair-elect. Steve will discuss the AHRMM Keys, key performance indicators for supply chain excellence, and how the keys can help healthcare supply chains benchmark their own operations to evaluate and improve their strategic goals and ultimate outcomes of patient health. Steve and Tom, thank you both for joining us today. Tom, I will now turn the presentation over to you. The floor is all yours.
Thank you very much. What a pleasure to be addressing the audience today and talking about the value of data and helping make good decisions, particularly in times of crisis like we're experiencing at the moment. Premium on good data in order to be able to make optimal decisions, giving the necessity of turning decisions around in very rapid time frames and getting to the best outcomes when sometimes the full picture isn't readily available to all of us. A little bit of background on the report on business that ISM has been publishing in one form or another since the 1930s. You may be familiar with the ISM index, people in the audience, from hearing it discussed on a monthly basis in terms of its impact on the U.S. economy, or what it says about the current state of the U.S. economy. It typically is covered on CNBC at the day of release. It's covered on the Wall Street Journal and other major outlets. Here's an indication of some of the coverage. It's internationally covered as well, the Guardian newspaper here in England. And then the president himself frequently cites data elements from the PMI reports when they come out. We published the PMI for the manufacturing sector on the first business day of the month, and for the services or non-manufacturing sector on the third business day of the month. And the hospital PMI is our first foray into an industry vertical version of the PMI, if you will. It's the first time we focused on the factors that are specific to an industry. And we thought, what better industry to focus on than the hospital sector, right? One that's been going through massive amounts of change, both in the statutory and regulatory arena, changes in the way that reimbursement flows in the system. And of course, it constitutes between 18 to 20% of the U.S. economy as an industry sector overall. That's healthcare broadly, not just hospitals. It's massively important. As healthcare goes, one can argue, so goes a large portion of the rest of the U.S. economy. We've been working with AHRMM for over a couple of years now in terms of trying to determine the best way to do this and to collect data and to begin to validate it. We started the data collection back in April of 2018. I'll show you a timeline in a minute of some of the development efforts behind this. course, none of us anticipated the pandemic outbreak, in the spring of this year in the United States and late winter, early spring in China, where it began. But it only increases the importance, I think, of the ability to make better supply chain related decisions in times of massive disruption and change for the healthcare sector as well as other parts of the U.S. economy. It includes, you should know about the hospital PMI, we use the same question set that we use for all other services sector reports, whether you're in hospitality or financial services or you name it. But we've added some additional questions that are specific to hospitals or designed to produce unique insight for hospital decision makers, whether they're in administration or in supply chain, or frankly, even people who follow the hospital sector uniquely. That could be the investment community, for instance, or regulators. So here's a little bit of a timeline. ISM and AHRMM, along with a strategic marketplace initiative, have been working on this for, well, a better part of 4 years. The initial discussion happened back in 2016. Convened the first advisory committee meeting in the fall of 2016, and over a series of meetings, we determined the final set of questions about 3 years ago, almost to the day from where we are today. We introduced some new technology at ISM, and we began collecting data using the new technological platform 2 years ago, a little over 2 years ago. It was important for us to understand the trend of the data over a multi-year period to validate the data, to make sure that it was actually measuring what we thought it was measuring. And it's also important for us to be able to provide some historical context so that when we launched the Hospital PMI earlier this month, people were able to look at that single data point for the month of July. So when we publish in the beginning of August, it's the data we've collected in the prior month. But understand that in the context of a 2-year period. What does the number mean? Is it good, bad, or indifferent? And what are the insights I should develop from having that index placed in front of me? So moving on to the next slide. Pardon me while I pull that up. There we go. The advisory committee is comprised of, or was comprised of, people that I think you know very well. So I was part of that effort, of course, and my lead economic researcher, Paul Lee from ISM, was also part of that. Debbie Sprinzunas, obviously the executive director of AHRMM. Mike Schiller was there in the beginning and all throughout this process. Dennis Orthman, then with SMI, was part of it. And then from the AHRMM board, we had Mary Beth Lang, who was at that time at the University of Pittsburgh, now with Kaiser Permanente, Karen Conway, Mary Beth Briscoe, Gary Fennessy, was very instrumental in helping us think through some of the questions, John Rittler and Eric Berger. So we had the benefit of a lot of industry experience in putting together, particularly that hospital-specific and unique questions that were critical to developing this particular report. In May of this year, we approached Nancy LeMaster. I believe Nancy's well known to most people in the AHRMM community, and asked her to play the role of what we call the survey committee chair, the person who gets the data once it's collected by ISM and gives it a once-over to make sure that she reads that data from the point of view of a seasoned practitioner who understands the hospital sector, the environment, and can put the findings into context that makes sense for people who work in the hospital sector in particular. So Nancy, as you know, was at BJC. I don't know if, Steve, you overlapped with her at BJC, but I know that's common to your background. She's been active in AHRMM and SMI for many years. So moving on, I'm having a little trouble advancing. There we go. Well, what is the Hospital PMI? I want to give you a little indication of what we're exactly talking about here. The PMI index is calculated by taking the unweighted average, or just dividing by 4 essentially, the underlying indices for business activity, new orders, employment, and supplier deliveries. A reading above 50 would indicate expansion, in the hospital sector, and a reading below 50 would indicate contraction. Now, technically speaking, the PMI is what is known as a diffusion index. A diffusion index is designed to measure the prevalence of a phenomenon in a set of data and also the sort of speed of change. So the higher the number above 50, the more widespread and the faster the pace of change is. And similarly, for a number below 50, the further below the 50 line, the more widespread and the faster the change in a contractionary direction. You can see since we began collecting data back in April 2015, look at the bottom left-hand chart on this slide, you've been consistently, the hospital sector has been consistently above 50, and then it takes a noticeable turn, right? In February of 20, it began to spike up, and I think that was the beginning of the preparation for the onslaught of COVID-19. You know, we were getting ready for what we were expecting to happen to our hospitals. Then in March, it began to decline. In April, it reached its or May, it reached its sort of low point, and then back in July, we started to, in June and then in July, we began to get back on that trend. If you were to draw a line from, say, December of 19 through June of 20, just a straight line through there, you can see kind of that trend of overall expansion is continuing at about the same pace of acceleration. What we all know, what we certainly have observed at ISM from the data that we collect, the hospital sector in that February to June timeframe went through a particularly difficult period. As you all know, most elective procedures in a hospital setting were postponed to be in a state of maximum preparation to deal with the incoming number of COVID-19 patients. And there was a surge in demand for healthcare and for COVID-related care at that time. But it created this twin dilemma for the hospital sector, which is we saw a surge in demand with also a rapid decrease in revenues being brought into hospitals. So it was a classic tough place for the hospital sector, having to provide more healthcare, but having less funding flowing into the hospital in order to provide it. It was a very difficult place. I think we've self-corrected out of that a little bit now. That's why the number is back at 68.9, which over the 2 years plus that we've been collecting data is actually the highest reading that we've ever seen. On the right-hand side of this slide, what you're looking at is actually the text of the report as it gets published on the 5th business day of the month. If you're not getting it already, you can get it from the ISM website at 10 a.m. Eastern time on the day of release. And right here in the beginning is that quotation from Nancy where she talks about the specific implications for what's happening in the hospital sector based on what she's reading in the data. For instance, she's talking about the case mix index being unchanged, the reading of 81.5, changes in days payable outstanding having increased by 4 percentage points, which doesn't surprise me given the scenarios we just discussed. So that's some of to give you a sense of some of the detail that you can expect to obtain based on reading the report on a monthly basis. Moving on to the next slide. These are the various sub-indexes that we are capturing in the hospital PMI. Some of them I've already mentioned: business activity, new orders, employment, and supplier deliveries. Changes in inventories, changes in prices. Now, in the hospital PMI, we specifically ask for changes in prices in the pharmaceutical area and in other supplies, which is a specialization specifically for the hospital PMI. You should know that in a diffusion index, by the way, when we're talking about changes, we're talking about changes compared to the prior month. And the only possible responses are, is it same, better, or worse? So take pharmaceutical prices. Are they the same compared to what I was paying last month? Are they better, meaning lower from a hospital point of view, or are they worse, meaning higher? So that's what we're tracking. How's your backlog of orders? What's your new export orders? What's your inventory sentiment? And by that, we typically mean, do we have enough inventory on hand? Do we not have enough inventory on hand? Do our suppliers have enough inventory on hand? How's your case mix, your DPO? How are your touchless orders trending, and how is your technology spend trending? Being, I know, a major focus for all hospitals, particularly as technology continues to be a big factor in the delivery of care. those are the individual components that we're tracking. Here's what the report looks like as it's published, along with the charts that come out. And this is the data that you would be able to read and provide you with some insight. So you understand where the overall index is, you understand where that index is in relation to prior months, and then you understand the component indexes that go into it: business activity, new orders, and employment, and then also the specific sub-index data that we are capturing. In the case of the hospital PMI, we're talking about the composite index being composed of those 4 sub-indexes that I mentioned already. You're also capturing verbatim comments from the panelists. This is a very important source of insight when people are talking about the experience they're having within their own specific hospital, their observations about what's driving the change month over month in the numbers. And Nancy, as the survey committee chair, is responsible for reviewing all of those verbatim comments and highlighting those that she thinks are emblematic of a theme that she's picking up on, or particularly interesting because maybe there's a variation or variance from prior months. Whatever reason Nancy believes they stand out, and that's one of her critical contributions, given her background, is noticing something that would be of unique interest to practitioners in the field. Published a 12-month history of the index, so you can relate it, a 4-month history for all of the 16 sub-indices, and then the panelists, the people who provide the data, receive a complimentary copy of the full report each month. By the way, this is a good opportunity to make that plug. We're always looking for new people to join the panel. The broader the data set, the more representative it becomes of what's happening in the hospital sector. We have validated it, so we know that it's accurately measuring the phenomena that we're setting out to measure. But more is always better. So if you have an interest, please reach out to AHRMM and they can put you in touch with the folks who can get you on the panel. The persons who participate in the panel and the organizations they work for, that information is always held in confidence, never disclosed. Obviously, there could be some sensitive or proprietary information associated with any given institution, so we never disclose that information. So if you were to participate in the panel, that would be on a purely confidential basis. All right, so here's the hospital PMI sort of at a glance, and here are some of the comments from the panel that I was talking about earlier. We're struggling with the reduction of regular use of our facilities by patients, right? So that was the elective procedures going away. We have put off some purchases of non-essential items, deferred some capital projects. I'm not at all surprised to hear that, but it's good to have that information validated by someone in the field. And there are other comments here that I think can help you understand, if you're evaluating this information for your own specific hospital or health system, is my experience similar to that of my colleagues around the country? Is it different? If it is different, why is it different, and how is it different? And these are the kinds of insights that we're hoping, questions that people will ask. Ultimately, the hospital PMI is designed to help you make decisions in real time that optimize your supply chain planning. And by asking these kinds of questions and understanding what may be driving what you're experiencing versus others in the industry, you should be able to calibrate your strategies and plans accordingly. And of course, here's Nancy's overall comment on the left-hand side, where she says that disparities in resumptions of elective procedures was causing a lot of the variation in the month of that report. And of course, PPE continues to be a major problem. I don't think that's going to go away anytime soon. How do you use the hospital PMI? Well, when I talk about the PMI and the services PMI to audiences, when I'm talking about the economic implications, I refer to it as a kind of a speedometer for the U.S. economy. The two PMI numbers taken together directly correlate to the rate of change in U.S. GDP and do so very accurately, which is one of the reasons why they're followed so closely. They also correlate very directly to the experience of inflation in the U.S. economy. Those are two ways that you can use, the broad PMI numbers to understand what's happening macroeconomically in the United States and how that might impact hospitals overall. It helps you gauge hospital consumer confidence and use those real-time insights to kind of fine-tune your strategy. On the day that the Hospital PMI was published, a friend of mine in the industry, Tom Nash, who's the Chief Procurement Officer at the American Red Cross, sent me a note and said, Tom, this is really great data and it's extremely beneficial to the American Red Cross. And we talked about it briefly, and the American Red Cross wasn't, of course, the direct intended beneficiary of the data. But I said, so Tom, tell me more. Why is that so valuable to you at the Red Cross? And he pointed out that among the other businesses the Red Cross is in, it sells about $2 billion worth of blood and blood products to hospitals every year. So this is a good reading for them on the financial health of one of their major customers. So here you go. Early insight into the business health of our hospital suppliers and hospital customers. So the Hospital PMI will have broader, I have no doubt about this, will have broader utility for not just the hospitals, but other people whose success or whose future is intimately tied to what's going on in the hospital sector. We'll have a broad audience. I'm sure that academics and regulators and policymakers will follow the Hospital PMI as closely as people in the industry do as well. So here again, here's a chance to, an invitation to join the Hospital PMI panel. Contact the folks at AHRMM or Chris Brazil here at ISM World, cbrazil@ismworld.org. It's completely confidential. Even I will not know your identity or the name of the organization that you represent. It takes about 15 minutes a month, and a great opportunity for you to not only give back to the profession, but to earn some professional benefits in terms of contact hours for CMRPs, recertification, and developing broader insights on behalf of your company. So please, if you're at all inclined, talk to your bosses about that. We'd love to have you. So in summary, we've been collecting the data since April of 2018. So we know that it's valid and the insights correlate to real changes in the sector. We have the same depth of data, so we can see the relationship of the hospital sector of the economy to the overall services sector of the economy, and actually to the manufacturing sector as well. And we believe the data that we're collecting will enable you as practitioners to make specific real-time changes and adjustments to your supply chain planning that will enable you to be more agile, respond more quickly, and better enable your hospitals to serve the communities that they serve. So thank you for your time and interest and attention in the topic. And Mike, I guess I'm going to turn it over to you for any Q&A.
Yes, sir. Thank you, Tom. That's a great presentation. And I'll tell you, it's been a lot of work, to your point, Tom, the better part of 4 years, but it's really exciting to see the product launched and to see the value that the data is bringing to the healthcare supply chain and the leaders within the healthcare supply chain to utilize that, right? Again, to guide strategic planning, strategic thinking. And the addition of Nancy is just a great add to the team and the insights that she brings and the experience she has. So a great project. And again, encourage everybody to reach out if you're interested in participating. Tom had mentioned a number of the benefits. I don't want to go ahead and reiterate those, but please reach out if you are interested in participating in the monthly survey. So at this time, we can take some questions. If there are any questions for Tom, as a reminder, please type those questions in the Q&A box, again, which can be opened by hovering your mouse at the bottom of the WebEx browser and clicking the ellipses icon, and then clicking Q&A. So we'll give folks just a minute to gather their thoughts and enter any questions that they might have, Tom.
Okay, I think I'm seeing some questions pop up. One is around whether the slide materials will be made available. I think the answer to that is yes.
Yeah, we will share this deck after the webinar, so that will be available. Any other questions that the group has for Tom at this time? Great opportunity to get a hold of Tom. He's a busy guy, and we're really happy to have him join us today. So please take the opportunity to ask any questions you have. All right, well, let's do this. Tom, we'll keep an eye on the Q&A box, and after Steve's presentation here, we'll come back to any questions that folks have regarding the hospital PMI report. Again, thank you very much for your time and you and your team's effort and collaboration and making this report, bringing it from vision to reality. So very excited to be a part of that team and a part of that process. So thank you, Tom. And Steve, let's turn it over to you and hear from you about the AHRMM Keys project. So the floor is all yours, Steve.
Thanks, Mike, and thank you, Tom. I enjoyed hearing about the new index that's available for our industry, which is great. The AHRMM Keys project, which recently launched, came as a result of some conversations that occurred at an AHRMM board meeting, or a couple of AHRMM board meetings, around measuring the health of the supply chain, especially in healthcare. And it really started then as a conversation around, supply chains measure a lot of things. Healthcare measures a lot of things. But what are some key things that we should be measuring, specifically from the lens of moving upstream, if you will, or at least for supply chain, people who work in supply chain and healthcare, when you're talking to your boss or the C-suite of your healthcare organization, what do you wish they knew about your supply chain when describing the health of your supply chain? And I know, having been in that role, like many of you are, oftentimes the conversations have a tendency to focus on unit costs, cheaper products, how much are you saving me, and the conversation is larger than that. And so we put some committees together, we put a task force together. A lot of you out there, and probably some of you on the phone, participated in those task force, and we had some roundtables at the AHRMM conference last year, to get feedback on what those things could be. And the result of that is what we're about to share with you, the first round of that, and then we're going to talk about what is coming next. So if you look at the purpose, it was to identify key performance indicators for healthcare supply chain to really equip our leaders with information to measure their own performance against themselves over time, and to quantify the value of supply chain to executive leadership. And as you all know, you play a critical role in your organization, and you can have an impact on many aspects of the care that is delivered. So if you think about the CQO movement that has been in place for quite a bit of time, and this helps put some measures around that CQO, because we do have an amazing impact on the quality of care. We have an impact on clinician satisfaction, patient satisfaction. We can have a bigger impact on the organization than just cost and savings. And so with the result of the task force, we got several of you together and said, what are some things that we can measure today? We know that it's available in the systems. We can get to the information. We can publish it and start to create this balanced scorecard approach in measuring the health of the supply chain. And again, the goal of this was really to help with conversations to healthcare leadership, because I believe we all do very well at measuring our supply chain, especially as we're measuring our supply chain downstream to our stakeholders, in those areas, and connecting with those team members and associates in the value that we do for them. And this is how do we do a better job at the value conversation going upstream in our organizations. So phase one, which of course just launched July 1, we did focus on 12 essential KPIs that we believe at a minimum every healthcare supply chain should be measuring and is capable of measuring. They're basic metrics, and you can measure them in any setting. So large acutes, complex integrated systems, to single hospital, single location systems, to non-acute systems as well. And this initial category are finance and operations type metrics. And then you'll see in the next phase, we're going to add additional areas that we want to measure to create that balanced supply chain scorecard approach. I'm not going to read through all these, and I'm going to leave them up as I talk through kind of the process. And for those of you that are familiar with HFMA, did a similar project around revenue cycle metrics. And so we came up with AHRMM Keys as we took their framework and adopted a similar framework around establishing the keys and how we put definition around those KPIs, how we communicate the formula, etc. And so by taking something that was familiar in the industry already, and AHRMM had already had a collaboration with HFMA some time ago where we agreed on the definition of medical supplies, right? So what goes in when you're evaluating a supply cost? So what are the inputs to that? And so we took that format in putting our AHRMM Keys together. And as you read through here, you can see that there are many of these, probably all of you are measuring today. There might be some that you're not. And they are more financial and operational. So they're pretty entry-level, basic type of measures, but they're ones that are important in communicating a bigger picture of what's going on in your supply chain, and especially now that we're in this pandemic situation and are experiencing unprecedented situations, we're all asking questions around what are some things that we wish we could have known about our supply chain that we didn't or couldn't. And so as an example of what this looks like in publication and in format, here's a couple of screenshots we're going to show you from the AHRMM Keys website. And essentially, so for every one of those 12, we give you a purpose of the KPI, the value, what does it mean to you? We actually, here's the equation. We'll do an example of calculating that equation. Then we're going to have information around what does that include. So as you think about the inputs, what are the inputs to that information? What are the exclusions from that? What don't we put in that calculation? And then we have a section in each of the keys around sources of data. Where can you go find this information in your organization and in your system to do the calculation? And then the team members, the task force participants, put together points of clarification, so things to think about as you measure your own performance against yourself. And we talk about, what does trending up mean or trending down mean? And then we add in references that you can click on and read about things other organizations and other industries have published on these KPIs. And a lot of these KPIs can be found in other industries as well. And all of these the task force members that were included in this work are all people that work in healthcare supply chain, on the provider side, on the manufacturing side, on the distribution side. So a lot of good viewpoints and perspectives in putting this together and coming up with this initial set of KPIs. So what does it mean now? So we have those, and again, our goal is to align to the quadruple aim in healthcare, which is improve patient experience, lower costs, improve clinical experience, and better outcomes, as well as the CQO movement, and bringing all this into alignment to stay consistent with the AHRMM mission and the AHRMM goals. And then now we're working on phase 2. So again, we've pulled together several working groups, and I'm very thankful for my co-chair in this effort, Mike Duke, who a lot of you know very well and has an amazing amount of experience in this topic and is very passionate about it. And we've pulled together several working groups who have volunteer members that are involved in this conversation around how do we develop the next set of this balanced scorecard. So what are KPIs that are supply chain centric KPIs that measure supply chain's impact on patient safety, clinical quality, effectiveness or efficiency, or supply chain resiliency. I think resiliency is a really interesting topic, and one that I know Tom and I talked quite a bit about when we were preparing for this presentation around what does resiliency mean in healthcare supply chain? What does it mean in any industry's supply chain? And it's a common conversation happening today. Supply chain's impact on engagement, satisfaction for staff, physician and clinician engagement and satisfaction, physician burnout, and environmental sustainability. So, which brings me to our first kind of polling question to try and make this interactive would be, as you think about your organization, and what do you wish you could have known about your healthcare supply chain that you don't know or didn't know or couldn't know? In which of these areas would you like to see a focus for these work groups that are working today in this next round? Where would you like that work to occur for your organization? And we'll give a few minutes for people to participate in that. You should, in the same way as getting to Q&A, is the same way you can get to the polling question, and we'll give a minute for that. And while that's happening, there is a question that did come in that said, is there any future plans to collate KPIs and share that with other healthcare organizations to evaluate ourselves against our peers? And along with that, will there be any differentiation by hospital size to more closely align? So it's essentially creating a benchmarking capability. And those are conversations that we're having with the task force and with our working groups around, what something like that would do and what AHRMM's role could be in that. And it's a conversation we're having at the board level as well with AHRMM staff. And what I would say is and as we go along that journey, one of the great things is that by AHRMM establishing a standard, if you will, around a standard set of KPIs, that it helps normalize the conversation so that we get everyone aligned to data standards. We get our industry then aligned to these are the things that are important to measure about our data. And then it helps us have those kinds of conversations where if I feel like my organization is very similar to your organization, and then we know that we're measuring the same things, we can have those kinds of comparative conversations to learn from each other about how we better manage and measure our supply chain. And I think the results are in for the survey. And no answer. It's like, well, there's too many choices, so I can't pick anything. But a lot of interest, obviously, in healthcare supply chain resiliency, in supply chain efficiency, clinical quality, are probably the top three winners that come out of that polling, and we do thank you for that. And then the other thing is I want to invite participation. So similar to the conversation that Tom had on the index is while we do have working groups in process and task force in place, if you have an interest and a passion for this area and this topic, please participate, right? Reach out to the AHRMM staff, reach out to me, reach out to Mike Duke, and we'll get you connected and plugged in to help, because it's a very important conversation as we think about measuring the quality of our supply chain, especially changing the conversation from it being solely about cost and savings, because supply chain means so much more than that. And then we have another question. It is an open-ended polling question, so you're going to respond to this using the Q&A box process. and that is, what has the current pandemic taught you that might be a good KPI to measure resiliency in your healthcare supply chain? So as you think about resiliency, what are your thoughts around how do you really measure that in the lens of healthcare supply chain and in the lens of what we've all been experiencing with this pandemic? And I'll leave it a few minutes for people to think about that and get that typed in. And I think this would be a good spot, because resiliency is such a common theme across all supply chains. This might be a good point to just share for me personally. One of the big ahas in spending some time talking to Tom and preparing for this and the work that we've done is healthcare, and having been in healthcare for my entire career, we often talk about everything healthcare could learn from other supply chains. And we know all kinds of healthcare systems have gone and hired great professionals from other industries to come work in healthcare so that we can learn from other industries. We can bring those learnings into healthcare. And I know I've heard, been in webinars and sessions where people have talked about healthcare and we're decades behind other industries when it comes to health, to supply chain. And my aha was, what the pandemic has taught me is that no supply chain was ready for this. And there's a lot that we can really all learn from each other, because some of the most regarded and revered industries when it comes to supply chain weren't ready for this either. And that's where that was just a really big aha for me. And I enjoyed Tom's feedback on that when we were conversing on that earlier.
Yes, Steve. We conducted some research around that, and you're exactly right. We found that in the early days, when China went into lockdown in response to the pandemic, the almost immediate result was a doubling of lead times across supply chains in every industry, not just the medical supply chain. So, and then at the same time, there was a huge transportation imbalance because we didn't have product moving from China to other markets. And so we had a lot of empty containers sitting in Chinese ports. We didn't have labor in those ports to kind of decongest the ports, and we shut down airline traffic, So we had no air freight and no ocean freight moving product. Even if we could get production up and running and get orders fulfilled, we still couldn't move it. So that did affect every single industry, and I don't think we've ever experienced an event that was really kind of economy-wide. We've seen disruptions, in Thailand with the floods in 2011, that was the hard disk drive industry. The tsunami in Japan in 2012, disproportionately automotive. And this is the first sort of recent event that impacted every single organization. And you're right, no one was prepared for the scope of this.
Excellent. Thanks, Tom. Just a couple of great comments in there coming in on measuring resiliency. I like the days on hand in the pandemic supply room. And there is a question that says, are there plans to extend KPI to include CSC metrics for those systems that have CSCs? And so for that part, it's not on the current roadmap, but we'll take that as a note. And again, with the lens of how do we report to the C-suite the health and value of the supply chain organization to that organization. But I appreciate that. We'll add that to our roadmap. Also, regarding the benchmarking, could this lead to a COE certification for supply chain? And I like that track, and it's conversations that we are having. I don't know where we're going to end up on that, but we absolutely, that's one of the things that we're also discussing as we get into phase 2, 3 plus, if you will. And I think we can add to this AHRMM Keys. We can build on this for a few years to come as we get better at measuring, we get better at data and information and reporting and sharing, breaking down some of the firewalls in our industry to bring supply chain transparency and visibility into fruition, from raw materials to final use in the delivery of care. KPI to identify the diversity and depth of your supply and inventory suppliers, right? So having diverse supply availability, UDI adoption absolutely is key to resiliency. Because if we don't all agree on how to report data, we can't get our data to be meaningful. That's absolutely, and having a backup plan. Keep those suggestions coming for sure. And again, if you're interested in participating, and reach out to myself, Mike Duke, anybody in the ARM staff, Mike Schiller, et cetera, and we'll get you plugged in. And the questions are kind of rolling in. I think we'll open it up in general to any other questions related to either KPI or the index. I think there was an index question that did come in a minute ago. No, I can't get it to scroll. But...
Yeah, I've got it, Steve. The question was, Tom, you had mentioned the information, the reporting is being validated. Can you explain that validation process?
Yeah, without getting super technical, there are two ways that we're validating it. One is use a number of statistical methods to look at variation among the data and make sure that we are not experiencing any kind of skewing in the data, or that our own methodology isn't introducing some kind of a bias. So there are a number of statistical processes that we use to make sure that the data collection is valid and relevant. And then we corroborate it against external data sets to make sure that what we think we're seeing in the PMI data, the hospital PMI data, is consistent with what's being reported elsewhere. So we do that over a 2-year period to make sure that we are putting something out there that people can rely on, as accurate. Now, when I say accurate, I mean directionally accurate, right? From month to month, there is always going to be a little statistical noise in any statistical measure, but so I'm not saying it's 100% accurate, but I'm saying over an extended period of time, the data proves to track with the underlying phenomenon that we're measuring. So that's how we do it.
Excellent. Thank you, Tom. I just want to encourage our listeners to continue to enter any questions either into the chat or the Q&A box. And while we're waiting for more questions to come through, let me pose a question to both you and Steve. You've talked about resiliency. That certainly has come up in a number of conversations that I've been involved in. Another topic that's come up is transparency and the need for transparency. I think there's been just increasing frustration and the lack of transparency, not only within the four walls of a health system, but upstream within that healthcare supply chain, the distribution level, the manufacturing level, maybe even all the way back up into the raw materials sector, but also the need for that transparency to be bi-directional, so that not only are we trying to look upstream, but manufacturers have that visibility out into the field, at the distribution level, and at the hospital level. I'd love to get your thoughts and opinions. How do we tackle this? How do we clear this hurdle on transparency?
Well, it's a significant issue in any industry, not just in healthcare. Even in industries that have kind of a reputation for being advanced practice in this area, most companies would tell you they have very little visibility beyond tier 1. So now it's getting a little better, and technology is helping us get to tier 2 and tier 3. And there's more of an imposition on the buyer on his sub-tier, through his tier 1 suppliers to the sub-tier suppliers, to give me more data and information about who you're working with and helping me understand, what our potential exposure is. I mean, in the case of healthcare, uniquely, I don't think the world really appreciated that 80% of active pharmaceutical ingredients that come into the United States come from China. And that's been a multi-decade process of pharmaceutical companies, U.S.-based companies primarily, but not just in the U.S., looking to lower cost, and sort of raw material level chemical production is largely shifted to China versus other places in the world. And that decision gets made time and time again, and it makes sense on an individual company basis, maybe even industry basis, but it's only after the fact we realize, holy cow, is that a strategic vulnerability for this country to realize that 80% of active pharmaceutical ingredients come from one country that, for its own reasons, might decide to turn off that tap at some point in time? Similarly, with rare earth materials, which are the metals that are used to make our sophisticated technology products, our cell phones, our laptops, and our medical devices. 80% of the world's supply of rare earth minerals comes from China. And there's a strategic vulnerability there. So technology is helping us with the transparency problem. At the same time, as we gain a little more transparency due to crises like this, it creates an environment, in my opinion, for looking at some strategic vulnerabilities in healthcare and maybe creating some new policy in this country around, I don't know, we have a minimum industrial military base, for instance, by policy. Maybe we need one similarly in healthcare. And I know that policymakers on Capitol Hill are very actively interested in that question right now. So transparency leads to, I think, some new policy questions that could be very interesting for healthcare in the United States.
I agree, and I think that to relate to a question that came up, do you think it's going to take federal mandates to make that happen? And maybe, right? It might. If the industry can't fix itself, somebody's going to have to force us to fix it for us, right? And there's also this in healthcare, because a large amount of healthcare is so concerned about privacy, right? For all the right reasons, because there's a lot of data in healthcare that should not be readily available to anybody or to only certain people, as you think PHI and things like that. And so all the systems in healthcare are built around this non-transparency, non-visibility, non-sharing role. And now as we're moving into more and more telehealth, and we're moving more and more, because of the pandemic, we're having to learn how to share all kinds of data in ways that we never were going to plan on sharing data before. And how do we treat supply chain data separately from PHI data? We don't have to do a one-size-fits-all, but a lot of the systems that are in place today aren't set up to do that.
Yeah, that's a big hurdle, Steve. And I'm sure you guys have heard the term shared economy, and just wondering what your thoughts are. I mean, AHA has the DVR program, the Dynamic Ventilator Reserve, where we've got the ability to move ventilators from areas of surplus, if you will, where the ventilators are not needed, to those areas where there's a great need. Do you see, in the spirit of transparency, do you also see the potential for a shared economy as it relates to medical equipment and perhaps even medical supplies?
I think there's potential, especially in regions, major metropolitan areas, or maybe some little larger geographic, state exchanges, et cetera. And that's where we have to get. How do we get health systems that are in the same place to rise above we're competing with each other into the things that we need to collaborate with each other on, to that point, which is not an easy journey.
I think that in the non-healthcare sector, it would be very difficult to get companies to agree to take that on. The profit motive is so overpowering. Carrying excess inventory is anathema in supply chains, right? And it's working capital I can't use. It's my profits. I think this is a role for government, much like we have the Strategic Petroleum Reserve, and we do have a medical stockpile in this country, although I think it's been underutilized. I think it's the role of maybe federal or state, possibly municipal governments, to create those exchanges, those stockpiles, and have them on hand for a crisis such as the current one. I very much doubt that you would get institutions, even not-for-profit health care centers, health systems, and hospitals, to volunteer to consume some of their precious resources to do this, because they're living on razor-thin margins as it is. So I think it's a role for the government.
And that's a good point, Tom. And I think that's one of the takeaways is the need for more collaborative conversations at that local, regional, state, federal level to bring the right stakeholders together to discuss how do we approach this more as a healthcare field, right? Collectively as opposed to individually. Certainly having 5,500 hospitals go out and develop their own surge inventories for PPE is just going to put a further strain on an already scarce supply. So great perspectives, gentlemen. Thank you. We do have a question I'd like to...
I'll add to that, especially since you bring up PPE, is that what we've also learned from this pandemic is PPE is not a healthcare problem. Without proper PPE, restaurants can't open, manufacturing plants can't operate. So PPE has now become a global cross-industry problem, which probably needs a larger, government-run, some type of intervention there or assistance in managing that.
Exactly. Yeah. Great point, Steve. So we've got a question, and I think we'll wrap it up with this. One of our listeners states, isn't honesty of both suppliers and providers in the time of shortages the true qualitative measure? So I'm assuming from a KPI perspective here, Steve, would like to get your thoughts, and then Tom, if you've got any thoughts to share.
Well, so supply chains, we'd love to trust everybody we do business with, and we need to be able to trust everybody we do business with, but what is honesty? How do you measure that? I agree with you, and the ability to just be, and I read that as upfront, right? And the situation I will use as an example, which we'll go back a few years, but who all remembers when there was a plastic injection mold issue for male urinals, right? And all of a sudden, you shut down healthcare almost over, not being able to get male urinals because there's only a few mold suppliers, people that do that in the world. But no one knew there was a mold issue. All of a sudden it was all these back orders are happening, and nobody knew what was going on. And then everybody starts scrambling, trying to, find new sources. And this is where if the supplier would have been up front, the manufacturer would have been up front and go, look, this is what's going on. This is the plan. This is how everybody's going to be impacted. But everybody's afraid of the other person taking advantage of that honesty, right? So because manufacturers compete with each other, et cetera, you just create all of these, no one trusts anyone else when there's a crisis.
Yeah, and to me, Steve, that's a classic example of what we call the bullwhip effect. And, what happens is, a demand signal gets sent from, let's say, the hospital, as we're expecting a massive surge in COVID-19 patients, and we need these things. Goes to a distributor. Distributor sees the demand signal coming in from all of its hospitals saying, oh my goodness, massive surge. Better get in touch with the device the manufacturers, whatever, the pharmaceutical companies. It gets aggregated again, and by the time you get down to the raw material supplier, the bullwhip effect is so huge, there's no way they can anticipate. Now, of course, that demand signal has been distorted. It's not nearly as massive as it appears at the far end of the supply chain, but because we're all reacting on a kind of an emotional level, on a psychological basis around being prepared for a worst-case scenario, that gets compounded. To me, the answer to that is if we had a system-wide view of demand signals that were being sent, it could be anonymized. But, if a GPO or a distributor said, hey, wait a minute, I'm getting, 200% of the normal level of demand communicated to me from all of you guys, what the hell's going on here? Is that, we really expecting that, or are we all... If we had system-wide intelligence like that, where we could then have conversations that didn't single out individual parties, that could insert some kind of sanity into the process, and we could tamp down those demand signals and make sure the supply chains were better able to react to the actual demand and not the anticipated demand.
And that is the holy grail, moving to more of a demand planning model as opposed to historical purchase intuition model that we have. So With that, gentlemen, we are out of time. I thank you, Tom and Steve, for providing us with some excellent information, thought-provoking information, and ideas to discuss with our teams as we look to strengthen the data side of the healthcare supply chain. We really do appreciate you guys both taking time out of your busy schedules to speak with our audience today. Quickly, again, if you are interested in joining the KPI or PMI initiatives, please email us at arm@aha.org. Also, we will please let us know what you think of today's presentation by completing the survey, which will pop up as an external site at the conclusion of today's webinar. Again, thank you all for joining us in your continued hard work during these challenging times. Stay safe, everyone. Bye-bye.
Thank you.